Hello, everyone, and welcome to the Alberta Lymphedema Association's digital booth for the 2021 Canadian Lymphedema Framework Conference. My name is Catharine Bowman. I am a lymphedema researcher, advocate, and also the Vice President of the Alberta Lymphedema Association. Today, as part of our booth, I actually wanted to give a bit of an update on some research that's been ongoing in Alberta and some research I've had the opportunity to collaborate on with my research mentor, Dr. Linda Carlson, as well as some of my research collaborators, Ms. Lori Radke, Dr. Devesh Oberoi, and Dr. George Francis at the University of Calgary. So I'm more than happy to be able to share this work with you all. This research is published and is open access. So if you're interested in reading the actual research articles or papers that have come from this research, you're more than welcome to and able to access this online. I'm also more than happy to answer questions if you do have any. I've included my contact information at the end of the talk here. So my hope for today, before we get going, is to just share a few words, a land acknowledgement with each of you. I am presenting this talk in the city of Calgary. And so I just would like to take the opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, and recognize that the city of Calgary is also home to Métis Nation of Alberta Region 3. And I think it's important for each of us, in addition to, of course, taking in this land acknowledgement and thinking about these words, but also to reflect on our relationship with one another, as well as the land that we reside on and that we work on in order to move towards peaceful reconciliation. For our talk today, I have no actual or potential conflicts of interest. I did mention that I am the Vice President of the Alberta Lymphedema Association, but I won't be discussing my role as Vice President for the presentation today. So the goal of the talk here, as I mentioned, is to present some of the research that I've been involved in with researchers in Calgary. And the first talk that I actually wanted to present, or part of the talk, is to look at a systematic review of literature that our research group did. And that's basically compiling a number of different research articles, potentially thousands actually at the beginning there, on a particular topic, to understand what the current body of knowledge in the scientific community is saying about that particular topic. And so the goal of the research review that I had undertaken was to look at the quality of life and psychosocial implications of cancer-related lower extremity lymphedema. As a bit of background for each of us, I'm sure we're very familiar, but if you are not, lymphedema is a chronic, progressive, and potentially disabling disease. Worldwide, it's estimated that over 200 million people are affected by lymphedema, but currently in North America, lymphedema is commonly caused by cancer-related interventions such as lymphadenectomy, radiation. And we also do see that lymphedema exists across a number of different tumor groups or cancer types. So folks who have had, say, treatment for gynecologic cancer, melanoma, prostate, penile cancers are all potentially at risk for elevated risk for developing lymphedema post-operatively or post-therapy. We also have come to recognize that cancer-related lymphedema and lower extremity, in particular for this talk, does have adverse physical, emotional, social, and familial, as well as financial impacts on people experiencing lymphedema, as well as the people who are supporting the person who is living with lymphedema. And so I felt it was important to specifically evaluate the impact of cancer-related LEL or lower extremity lymphedema on patient quality of life and psychosocial well-being. We oftentimes do see literature that focuses on breast cancer-related lymphedema, so I felt it was important to also recognize the experiences of people with lower extremity lymphedemas from things like gynecologic, penile, prostate cancers, and so on. The specific aims of this project, or this systematic review, was to summarize and critically evaluate literature that's looking at that impact of cancer-related lower extremity lymphedema on patient quality of life and the psychosocial well-being. So this is psychologic, social, emotional, financial components of our well-being. So very much looking at the holistic experience. And I was also looking to identify potentially modifiable factors that are associated with poor quality of life and psychosocial well-being in patients who are living with cancer-related lower extremity lymphedema. And so I briefly explained kind of the process of a systematic review. And so what actually starts out is myself and the research group and my collaborators, we first aim to ask the research question and conduct a very detailed literature search based upon a set number of criteria for the types of articles we were looking at. We then were able to get actually, in this case, a couple thousand different articles or research papers into our hands, and then had to remove any duplicates after looking through a number of different databases online. And then started to see which papers or which articles and types of research are we specifically looking at that really fit a specific set of criteria, inclusion criteria for these papers. I then went through and read through different titles and the abstracts of the research articles. I then read the full research articles, and by the end of it, I was able to basically grasp a number of different research articles on this topic of quality of life and psychosocial well-being and cancer-related lymphedema of the lower extremities, and then summarized these articles through a data extraction process and rated the quality of scientific evidence that we were able to attain in these papers. So as I had mentioned, I used a number of different electronic databases, or almost like massive libraries, to obtain all of these different research articles. So I looked through a database called PubMed, ProQuest, and Scopus. And then when I was developing how I wanted to search for all of these different research articles, I really focused in on a couple different domains. So of course, focused on lymphedema, that of the lower extremities, that is related to cancer treatment, and then looking at the psychosocial well-being and quality of life, and basically typed in and created a search strategy based on these 4 categories. In terms of our inclusion criteria, when I was moving through each of the levels of screening, as we call it, so the titles and the abstracts and the papers, I was looking for papers that were published prior to May 2020, that were examining the relationship between cancer-related lower extremity lymphedema and quality of life, and psychosocial well-being. And so when we talk about psychosocial domains or well-being, we're looking at psychologic distress, physical, social, familial, emotional, and functional well-being, sexual function, body image, or financial implications. Upon creating my search, I actually yielded over 3,000 articles. And so I went through and tried to find which articles were specifically addressing that research question, the quality of life, and ended with 21 research papers. Within these 21 research papers, what I found was a total of 7,500 participants that were an average age of 60.7 years, and that were primarily women with gynecologic cancer history. Most of these studies, in terms of the types of studies, were cross-sectional design, prospective cohort studies, and retrospective cohort studies. And when the researchers of these articles were looking at how to actually measure quality of life and psychosocial well-being, these were the quantitative metrics, or the tools that they were using most commonly across the research articles here. So what did we find of all of this body of literature looking at quality of life and psychosocial impact of cancer-related lower extremity lymphedema? Well, we did find that there was a negative correlation between lymphedema status and global quality of life. So that's really looking at a multifaceted view of what quality of life is for the whole person. In terms of specifically looking at physical and functional implications, we found a negative relationship between physical and functional well-being in relation to a patient's lymphedema status. In terms of pain and fatigue, we actually found a number of studies, so 7 out of the 21 that reported incidence and frequency of pain and fatigue, and reported a negative effect on quality of life as a result. 4 of these studies were discussing activities of daily living and associated lymphedema with physical limitations, unmet needs, and interfering with activities of daily living. In terms of psychosocial, psycho-emotional implications, we had a negative relationship between lymphedema status and psycho-emotional well-being, so factors including sadness, anger, loss of self-confidence, appearance concerns, and then body confidence as well. And finally, from a social, relational, and financial standpoint, we also found a negative association as well. And so this is telling us, as we know, lymphedema is a progressive, lifelong, and poorly recognized condition, unfortunately, by many healthcare practitioners. Though, as I will present in my next next study or next phase of this talk, the willingness for people to get engaged in lymphedema education is very much prevalent in the medical community as well, which is wonderful. Currently, the literature is suggesting a negative relationship between cancer-related LEL and quality of life and psychosocial well-being. But we did find when we did kind of the quality assessment of these research studies that we are still in need of some really rigorous studies that are looking at more so the long-term implications or over time, how lymphedema affects the person in order to examine, the directionality of the relationship between these factors, as well as the temporality of these different factors. So with that, I'll move into the second half of the talk here, which focuses on a second study that I was able to contribute to in Alberta, and that's the Living with Leg Lymphedema study. And so I was able to collaborate with Ms. Lori Radke, Dr. Oberoi, Dr. Francis, and my supervisor, Dr. Linda Carlson, on this research study. And now the purpose of this study was to integrate perspectives of lymphedema patients and healthcare providers on lower extremity lymphedema related to cancer in order to develop a novel model for quality lymphedema care. And so specifically when we had actually kind of two different arms of this study, those that involved the patients and those that involved care providers who were caring for patients with lymphedema. For patients, we were specifically looking at assessing quality of life and lymphedema knowledge, evaluating the use and impact of management strategies on quality of life, as well as assessing patients' interest in expanding their current treatment regimes and the accessibility to actually be able to do so. In terms of our healthcare providers, we were looking to assess their lymphedema knowledge and as well their clinical referral practices. In Alberta, we do have publicly funded lymphedema care and programming. And so one of the clinical pathways, particularly for individuals who have had previous cancer surgery or previous cancer, is to be referred through to a rehabilitation oncology type of clinic. There's multiple in Alberta for this. And so we were looking at that referral pattern for care practitioners working within an oncologic practice. And then we were also looking at suggested interventions from the healthcare providers in order to improve clinical lymphedema care and continuity after cancer treatment. So as I mentioned, we have kind of two primary groups within this study. We have the healthcare provider participants who took part in qualitative semi-structured interviews on a couple of topics that I will discuss shortly. And then we had our patient participants who did the qualitative semi-structured interviews, but also a quantitative online questionnaire to use some objective quantitative metrics to measure quality of life and well-being. In terms of what those measures were within the patient participant category, we used the LymQual that looks at quality of life specific to people living with lymphedema. So asking questions more specific to lymphedema than say the FACT-G, which is more of a general quality of life for people who have been through cancer therapy. We also used the GAD-7, which is for generalized anxiety, and then the PHQ-H, which looks at depressive symptomology in that case. In terms of the qualitative interviews that I was discussing earlier, our patient participants, we talked about their diagnosis of lymphedema and what that looked like, whether they were referred to a clinic, and then some of the education that they were receiving, both at the beginning of their lymphedema journey and then now as patients who have been living with it for a period of time. We looked at their current management strategies and financial implications, if any, of management. We looked at experiences with complications and exacerbations, things like cellulitis, and thinking about the future of their lymphedema, and then the social, physical, and emotional aspects of lymphedema. For our healthcare participants, as I mentioned, we talked about that referral pathway, so we're looking at their practices from that standpoint. Their lymphedema education and knowledge and their awareness of the basics of lymphedema to the treatment, things like that. How they disseminate their knowledge to patients and how they receive their knowledge about lymphedema. And then finally, their thoughts on strategies so that we can improve care flow through for patients with this type of lymphedema. So of those who participated, we had 22 patient participants. They were about 60 years old, which if you can recall from our literature review, this is actually quite representative of the general lymphedema population. Majority of our participants were female and were experiencing previously gynecologic cancer. Most of our most of our participants were residing in a metropolitan urban center, and they did have private health insurance, which comes into play when we think about lymphedema treatment as well. For our healthcare providers, they were a mean age of 50.8 years, pretty even split between male and female practitioners. And those practitioners were working primarily within the gynecologic tumor group, though we did have representation from melanoma and prostate cancer clinics as well. And the majority of our participants were nurses, followed by staff oncologists, and then clinical fellows in oncology as well. And we also had a psychologist join us as well. So in terms of our quantitative findings, as I mentioned, the patients went through the questionnaire. What we did see is there was actually no significant difference between our participants with cancer-related lower extremity lymphedema to the general population and cancer survivor populations. We did see that our participants had similar limb qual or quality of life for lymphedema to the Canadian lymphedema population mean. They did have significantly lower quality of life, general quality of life, than general population and cancer survivor populations. And finally, we had significantly higher depressive symptom scores than the general population in this cohort. In terms of the qualitative data, I've broken up our patient experiences with our healthcare provider experiences here. And you can see there were 4 kind of primary factors or themes that came through that qualitative data, which I will talk through and provide some examples and quotes. And within these themes, we have sub-themes. So consistent points that came up for our participants that were moved through our qualitative data. So the first major theme here was looking at lymphedema education for patient participants. One of the quotes here that I found was very representative and strong to express how I think many of our participants were feeling is this one here that says, "There is always a doubt. This lymphedema is not going to get better, and most things don't stay the same. So that by extension means you're probably going to get worse. So what's that going to mean? Am I going to start walking with crutches or a cane, a walker? Am I going to be in a wheelchair? Am I going to die from it?" So within this quote, there were a number of things that kind of came through and other participants also discussed. Is there is a degree of uncertainty, especially around the future of patients' lymphedema. 16 of our patient participants felt they had a good understanding of their lymphedema, but few received their lymphedema education from healthcare providers after cancer treatment. Most of them were looking to other sources, magazines, internet, peer support to have learned more about their lymphedema. And all of our participants did describe an interest in learning more about lymphedema, new treatment research, treatment options, and the pathogenesis was a big thing, especially tying into that the future of lymphedema for a particular patient. 13 participants described the effect of that unpredictability and lack of knowledge on lymphedema pathogenesis, how this is impacting actually their fear of cancer recurrence and the fear of exacerbation with lymphedema. The next theme here was looking at barriers to care. So I talked about some of the financial implications of lymphedema, and that was one of the primary barriers that patient participants were experiencing when looking to continue and comply with their treatment, as well as looking for new treatments. And so this quote from one of our participants says, "My MLDs, and that's manual lymphatic drainage, I go for once a week, which are $100 a pop. That adds up. My pump was $10,000. The compression, you need to keep buying it again and again to make sure it works. So it's all expensive. There's nothing cheap about it." Another quote from a participant is, "The oncologist didn't know, the vein doctor didn't know, my GP certainly didn't know what it was, what was going on. Nobody knew. I just wished some of the medical people would have known about it. And so what this particular quote is drawing upon is another major barrier to care that we identified within our patient participant cohort. And that was knowledge of healthcare providers in actually being able to screen and diagnose lymphedema. And so we had some of our participants describing similar situations where practitioners didn't know that didn't know they had lymphedema. And so they were left without a formal diagnosis, in some cases for years, or very much a delayed diagnosis. And so delayed lymphedema diagnosis was the most commonly cited barrier to adequate care. The majority of our participants did not receive a timely diagnosis. Rather, participants began to self-diagnose through self-driven information gathering until a clinical confirmation was received. And participants discussed visiting multiple specialists about their lymphedema symptoms without receiving a diagnosis, suggesting that there is a broad expanse of lymphedema educational and diagnostic disparities within the healthcare system. Our participants our patients aren't necessarily just going to one type of doctor and they're unsure of what this participant or patient has. As we can see in that second quote there, patient was going to multiple different specialists and their general practitioner and not receiving that diagnosis. So there's really an opportunity there to educate on a more broad level. Our next major theme from the patient participants here is about resource accessibility and the timely referral to lymphedema clinics in Alberta. So the quote here is, "If I didn't do what I do, I don't think I would be walking, because prior to going to see the practitioners at the rehabilitation oncology clinic, I couldn't grocery shop. We would go to a market and I would sit up front and my husband would go and get what we needed." So 18 of our 21 participants described benefits of going to the rehab oncology clinic for initial lymphedema management, education, and self-care. Preliminary compression bandaging, limb volume measurements, and tracking, as well as self-care instruction were some of the major kind of resources or education points that patients were receiving when visiting the clinic. And participants also described the importance of lymphedema clinical staff in their education, but also in the long-term support and of their well-being. 16 participants accessed clinical services most heavily just after their referral or at the beginning of their lymphedema, then eventually transitioned into a more self-management, but were into the clinic for regular checkups as well as exacerbations, things like cellulitis, or unsure of why their lymphedema was flaring up. So it suggests, a model that you set people up for success with self-care initially, but there is always that kind of safety net or support that we did definitely see in our qualitative data. We also saw the theme of psychosocial well-being and fears of the future for our patient participants. So the quote here is, "It's devastating. You're not the person you were. You can't do the things you used to do. Because of my nerve pain, I wasn't sleeping at night. You don't feel good about yourself. You can't do the things you want to do." And another quote here, "As you get older, you can't get your own stockings on. Then you have to have somebody help you, and that ain't going to work. And without the stockings, I could easily be in a wheelchair." So what we noted in the data was there were a number of participants who were experiencing a decline in their psychosocial well-being as a result of their lymphedema experiences. Things like change in identity, immobility, a number of different aspects here really had tied into patients' quality of life, and the unpredictability of what's going to happen next with their lymphedema and their management moving forwards and kind of as it progresses really did play into people's fear of what would happen next in the future of their lymphedema and exacerbations. So moving forward here, I'm just going to discuss briefly some of the healthcare provider data from the qualitative interviews we conducted as well. And again, we have kind of 4 primary pillars of the data that came through, or the themes, as well as sub-themes that were identified along the way. And so the first major theme here was about lymphedema education. And so one of our healthcare practitioners here said, "I think that education is powerful, and especially when your patients look to you as the experts. Even if you don't know how to treat it, even if you don't know how to help, sending them to the right resources is the most powerful thing you can do for your patient." So with that, All of our healthcare participants were aware of lymphedema and able to describe things like signs and symptoms, potential screening strategies for lymphedema, what they do in their clinics, as well as their referral practices to the Rehabilitation Oncology Center. The majority of healthcare practitioners did not receive formalized teaching on lymphedema during undergraduate medical education. Rather, these practitioners received more experiential education through their clinical rotations when they were on the wards. Healthcare participants also identified the importance of lymphedema resource knowledge, especially when they were navigating treatment and medical supply options for patients. This was an area that some of our participants certainly felt like they didn't know as much about and would like to know more. And finally here, although one practitioner did not necessarily desire additional lymphedema education, feeling that they didn't see lymphedema come through their doors as much, the majority of our healthcare practitioners did indicate an interest in additional education on lymphedema and provided a couple of different ways through which they thought that would be able to come into practice, things like a lunch and learn. One practitioner suggested even shadowing some of the physiotherapists and interest in that. And so you can read more about that if you'd like in our research publication online. The next theme that we identified with our care practitioner participants was the resource accessibility and timely referral to lymphedema clinics. And so one of the quotes here is, "I do believe that the culture in general is that there's not much we can do about lymphedema. You know, it's only when the patient really makes a thing about it that we finally do something." And I think that's sad because we lack knowledge here. Our healthcare practitioners describe the importance of having the lymphedema clinic, the rehabilitation oncology clinic, and their role in providing adequate long-term support for patients with lymphedema. But several practitioners weren't as familiar with the specific resources and services that were actually provided within the clinic, what treatment actually looks like in long-term management, what that entails. Some participants did describe screening for lymphedema regularly after kind of in the post-treatment intervals, but others felt that screening was not conducted enough, leading to low levels of referral to the actual rehabilitation oncology clinic. Some participants used patient discomfort as an indication for referral, but others were using physical symptomology, so things like swelling, change in volume, or limb circumference. The majority of healthcare practitioners did voice the importance of consistent screening and referrals in order to optimize lymphedema clinic use. And so we did hear some interventions, and they are written within our research publication about how we could improve screening in order to improve that referral process as well. Some of the barriers to care that practitioners had identified here. One of the quotes is, "Thinking up, 2 or 3 simple questions that could be added to an assessment sheet might lead to earlier diagnosis and ultimately treatment of lymphedema." So we noticed that our healthcare practitioners cited inconsistent lymphedema diagnosis as the most common barrier to care, but it was important that we have efficient screening tools to actually expedite that diagnosis. There were a number of practitioners who talked about the importance of, thinking up a couple simple questions that could be added to either a pre-existing assessment sheet or developing a shorter new assessment sheet to integrate into regular oncologic follow-up care. Some of the challenges here too were with actually screening and diagnosing lymphedema were the variable timeline of onset associated with lymphedema. So we know that lymphedema may show up immediately post-operatively or many years down the road. And so in terms of the follow-up visit timeline within the actual cancer center, that created an issue for many practitioners to successfully diagnose lymphedema. We also are lacking, again, those referral protocols and those screening tools within the actual cancer clinic and kind of regular standard care flow. We also had varying patient follow-up after cancer treatment as another barrier to care. So depending on what type of treatment someone was receiving, if that was radiation oncology or medical oncology with chemotherapy or surgery, there was a variety of different follow-up timelines and care pathways that a single patient may occupy after their cancer treatment. But one of the major kind of factors that our participants identified in order to improve that continuity of care and get people into the clinic was increasing cross-departmental communication. So making sure that our practitioners in some cases didn't realize they could see the notes from the rehabilitation oncology clinic. And so making sure people recognize that that is actually something that's accessible within the cancer centers. And then understanding, what actually goes into lymphedema management once someone is referred over to the clinic was another important piece. And so with that, we took all of this different data and we actually developed a novel model of lymphedema care. And it's based upon a lot of the themes identified in both the qualitative, but also some of the quantitative data in terms of well-being. And it's 6 primary pillars, recognizing the importance of each of these pillars and how they interplay with one another in order to essentially address patient care and in an optimal way when it comes to cancer-related lower extremity lymphedema. With that, I want to thank you so much for your time. As I mentioned, our research articles are available online and they are open access. So even if you may not be working at a university as a researcher, or you may be a patient and don't have that access to these online articles, they are available to you. If you have any questions or would like to connect, more than happy to connect on LinkedIn, Twitter, my Instagram and my email are listed there. I do also want to thank my research mentor, Dr. Linda Carlson, and the Carlson Lab at the University of Calgary for mentoring both of these projects and all of this work, as well as our study team with Dr. Carlson, Dr. Radke, Dr. Oberoi, and Dr. Francis, as well as our clinical collaborators and our wonderful study participants. With that, I want to thank you so much for your time, and I hope you enjoy the rest of the conference. Take good care.